Predicting your chances of surviving a massive physical trauma might come down to one simple motion: walking up a set of stairs. Major operations, like a thoracotomy, where surgeons physically open the chest cavity, are highly controlled physiological traumas. They push the human cardiovascular and respiratory systems to their absolute limits. Before a surgeon picks up a scalpel, they face a serious diagnostic hurdle. They need to know if an elderly or high-risk patient has the internal fortitude to survive that immense shock. To find out, doctors typically rely on the Revised Cardiac Risk Index, or RCRI. It is a standardized checklist of existing diseases, tallying up a patient's history of past strokes, heart failure, or kidney disease. But the RCRI has a severe limitation. It accurately accounts for the illnesses a patient carries into the operating room, but it ignores what their body can actively do. Getting through extreme physical stress requires a dynamic measure of your body's hidden physical reserves. In clinical terms, doctors call this your functional capacity. To measure that capacity, a team of medical researchers tested 83 high-risk patients who were scheduled for intense abdominal or chest surgeries. The baseline danger here was severe. After surgery, 25% of these patients suffered major cardiopulmonary complications, meaning they developed severe pneumonia or sustained direct injury to their hearts. Before the operations even began, researchers put these patients through a symptom-limited stair climbing test to see if they could predict who would suffer complications. This chart maps complication risk. Patients unable to climb a single flight hit an 89% complication rate. Failing to climb 2 flights yielded an 82% predictive value for major complications. For those climbing 7 flights, the risk dropped to 0. This established a direct inverse relationship. The specific number of stairs climbable dictates the risk of post-surgical pneumonia and total length of hospital stay. The Garish study focused on 83 specific high-risk cases. The next step was determining if this clear biological rule held true across a much wider population. The basal PMI study expanded the evidence significantly. This hazard ratio visualization compares the outcomes of the two groups. Patients failing to meet the 2-flight threshold faced a 63% higher risk of cardiac death or major adverse cardiac events within 30 days. Clinically, this 2-flight threshold acts as a physical proxy for roughly 4 metabolic equivalents, or METs, a unit measuring the raw internal energy output your body can sustain. When doctors plug this self-reported stair data back into the standard RCRI checklist, their ability to correctly classify patient risk improves across the board. Incorporating this one physical metric allows doctors to identify high-risk individuals that a static disease checklist would have otherwise misclassified as safe. You do not need to be waiting for an operation to put this data to work in your own environment. A standard set of stairs is a live daily mirror. It provides a real-time reflection of your underlying cardiopulmonary resilience. Tomorrow, skip the elevator, find 2 flights of stairs, and test your own baseline capacity. The clinical parameters are strict. You must climb both flights consecutively without needing to stop for severe breathlessness or chest pain. If you pass, your functional capacity is currently sufficient to handle the metabolic demands of significant physical stress. If you struggle to make it to the top, the data provides a clear, measurable goal. Improving that stair climbing capacity is a direct way to move your body out of a high-risk category. Clinical evidence shows that the inability to climb 2 flights is a primary predictor of mortality under stress. Using those stairs daily is the most direct way to ensure your body remains well above that critical threshold.